Hello, my name is Corinne, and in this video, I will be analyzing a deeply personal and socially complex ethical dilemma in medical care: the use of prenatal testing to detect Down syndrome and the decisions parents make based on that information. The focus of this video is a real-life case from Amy Harmon's 2007 New York Times article, which explores how expanded access of prenatal genetic testing is leading more parents to choose abortion following a Down syndrome diagnosis, and how this trend affects individuals with disabilities, their families, and the broader healthcare system. The core ethical conflict is this: should society support and normalize the use of prenatal testing and abortion in cases of Down syndrome, or should it emphasize inclusion and the inherent value of all lives, including those with disabilities? To explore this dilemma, I will provide background on Down syndrome, prenatal testing, and recent medical practices. Then I will identify the conflicting ethical values at play. After that, I will apply several ethical theories, including utilitarianism, deontology, and feminist ethics, to examine the case from different perspectives. Finally, I'll reflect on my own stance and conclude with the broader implications of this dilemma in healthcare ethics. Down syndrome is a genetic condition caused by an extra copy of chromosome 21. It often leads to intellectual delays, heart defects, and other medical complications. However, many people with Down syndrome, like Sarah Ido from the article, live full, vibrant lives. Sarah is a Girl Scout, plays clarinet, and she proudly declares, "Even though I have Down syndrome, it's okay." Until recently, prenatal testing from Down syndrome was primarily offered to women over 35. However, with advancements in non-invasive prenatal screenings, NIPS, all pregnant women can now be tested early on in their pregnancies. What's concerning to many in the Down syndrome community is the outcome. Around 90% of pregnancies with a Down syndrome diagnosis end in abortion. Parents say that the information they receive is often framed negatively, emphasizing limitations and hardships, without showing what life with Down syndrome can actually look like. Many advocates fear that this trend could reduce the Down syndrome population, leading to fewer services, reducing funding, and increasing isolation for those few who remain. It also raises a broader cultural question. Are we creating a society where disability is quietly erased rather than accepted? This case presents a serious tension between several foundational principles in medical ethics. Number 1, autonomy. Parents should have the right to make informed decisions about their pregnancies, including the decision to terminate. This is grounded in respect for individuals' liberty and body integrity. Number 2, beneficence. Medical professionals aim to help patients by reducing suffering. In this case, doctors may see abortion as a way to protect families from emotional, financial, and medical hardships. Number 3, respect for persons, non-maleficence. Every human being, regardless of ability, has inherent dignity. Selective abortion based on disability may send the harmful message that these lives are less valuable, causing social and emotional harm. These values are in direct conflict. Respecting autonomy might mean supporting a parent's choice to terminate, but that choice may be heavily influenced by biased counseling, thereby violating the spirit of informed consent and non-maleficence. To better understand the ethical tension, I will apply 2 major moral theories: utilitarianism and deontology. Starting first with utilitarianism. This theory evaluates morality based on the outcomes. What produces the greatest happiness or least suffering for most people? A utilitarian might support prenatal screening and even selective abortion if they believe it minimizes long-term suffering. These parents may avoid emotional distress and lifelong caregiving. The child may avoid a life with potential pain and marginalization. However, a broader utilitarian perspective could oppose this. Reducing the number of people with Down syndrome could create a society with less diversity and compassion, fewer institutional supports, and increased stigma. If this causes greater harm over time, especially to disabled people, then the practice may not maximize happiness after all. Now on to deontology. Deontology focuses on moral duties, not outcomes. It emphasizes treating people as ends in themselves, never merely as means to an end. From this view, terminating the pregnancy based on disability treats the fetus as a burden or problem, not a person with dignity. All doctors have a duty to tell the truth, but not to influence choices through fear or bias. Many deontologists might argue that ending a potential life due to a diagnosis fails to honor basic moral worth of that life, even if it's imperfect or challenging. It's not about predicting outcomes, but also respecting rights and intentions. On the screen, I will put up a picture of comparing the theories. The two theories are utilitarianism and deontology. The focus of utilitarianism are the outcomes, and the focus of deontology are the moral duties. The likely conclusion for utilitarianism outcomes may justify abortion if it reduces suffering. There are also cautions against long-term social harm. For deontology, the likely conclusion would be likely opposes abortion based on disability. Every life has moral worth. I believe that parents should retain the right to choose, but their decision should be grounded in balanced, compassionate, and non-biased information. That includes seeing the realities of living with Down syndrome, not just the risks, but the value, love, and potential that people like Sarah Ido embody. This position honors autonomy by protecting choice, respect for persons by affirming the moral worth of disabled people, and non-maleficence by avoiding harm caused by fear based on incomplete information. And while utilitarianism reminds us to consider long-term impacts, deontology reminds us never to treat a person, born or unborn, as disposable. Dignity and care must remain at the center of decision-making. And I do acknowledge that some families face real hardship. And this isn't about moralizing their choices, it's about improving the ethical context in which they make them. In my view, protect choice, but improve the system so choices are made from truth and compassion, not fear or bias. Case number 2, Ferguson versus City of Charleston. This case involves a major ethical and legal conflict in reproductive and medical ethics. In Ferguson versus City of Charleston, 2001, the Supreme Court ruled that public hospitals cannot drug test pregnant women and report them to police without their consent. The ethical dilemma is whether it's morally acceptable to violate patient consent in order to protect fetal health. In this analysis, I will outline the background, identify the moral conflict, apply two theories, and share my position. In the late 1980s and early 90s, a public hospital in South Carolina began testing pregnant women, mostly low income, for cocaine use without their knowledge. If the test was positive, women were arrested at the hospital, sometimes while still recovering from childbirth. The hospital argued that this was to protect unborn children and push women towards treatment. But in 2001, the Supreme Court ruled 6-3 that these tests violated the Fourth Amendment as they constituted unreasonable searches without a warrant or consent. This case raised deep concerns about privacy, discrimination, and the criminalization of medical care. There are 3 core ethical principles. Number 1, autonomy. The woman's right to informed consent was violated when they were tested and reported without knowledge. Number 2, beneficence. The hospital claimed to act in the interest of fetal health, but their approach harmed the mother. And number 3, non-maleficence. Arresting women discouraged them from seeking prenatal care and caused emotional and physical harm. The hospital's attempt to help through coercion undermined trust and inflicted harm, especially on marginalized communities. Number 1, ethics of care. It emphasizes relationships, empathy, and contextual understanding. This theory would reject coercive policies that damage trust and punish vulnerable women. A care ethicist would argue that support, not surveillance, is the ethical response to addiction. Number 2, virtue ethics. This focuses on the character of the caregiver. A virtuous provider would act with compassion, justice, and humility. This theory condemns hospitals as tools of law enforcement, especially when doing so deters care. In conclusion, from both theories, ethical care requires trust, support, and respect, not criminalization. My ethical stance is that drug testing without consent is unjustifiable, even if the goal is fetal protection. Now, why do I say this? Because it violates autonomy and trust. It also causes real harm to the mothers and the babies. And it ignores the root problem. Addiction is a health issue, not a criminal one. Both ethics of care and virtue ethics support a model of care that prioritizes supportive relationships over punishment. Even if the intent was beneficent, the outcomes were harmful and ethically wrong. In summary, the just and compassionate path is one that builds trust, not fear.